A very warm good morning to all of you who are present in this August gathering, and I'm very thankful to AIMS for giving us this opportunity to share some of our experience in stem cells. So about my presentation, I'll be focusing on use of stem cells and myocardial infarct, and use of stem cell in dilated cardiomyopathy, and giving some of the examples that how we want to train these stem cells to differentiate into cardiomyocytes, and if time permits, a few examples of our bench work which has resulted in translation research and stem cell and tissue engineering. We started in 2003 and 4 when there was few papers which are published in Nature and Science, which states that stem cells can give rise to regeneration in animal models of myocardial infarct. As we all know that stem cells are present in bone marrow in abundant number. There are two types of cells, hematopoietic. Can you just guide me how to put the pointer here using this? Pointer, yeah, in the screen. So hematopoietic stem cells are present in mononuclear cells, which we used for clinical research. The mouse. I need the mouse. Thank you. Thank you so much. For all clinical purposes, we used hematopoietic, and for basic research, we used mesenchymal stem cells. So why did we use mononuclear cells? Because that was very easy to extract from the bone marrow, and we used all autologous from the same patient, going back to the same patient, as it does not have any ethical issues, and there was no question of tissue rejection. So this is the procedure which was done next to the OT in the cardiovascular department. We took bone marrow aspirate from the sternum, separated it out. It took around 2 hours to separate mononuclear cells containing hematopoietic stem cells, and then it was back injected into the patient. So our study was divided in 3 phases. Like number 1 was the pilot study. You can see here, it was done in acute myocardial infarct. The route was epicardial. Then there was followed by phase 1, which was case control and randomized, both in AMI and dilated cardiomyopathy. The route was epicardial, and in DCM, it was intracoronary. After going through the results of the phase 1 and another study, we conducted multicentric double-blind randomized trial to increase the number. So we have it only in AMI, and the route was intracoronary. And this was done after appropriate approval from the ethics committee. So I'll just start from the pilot study, which was published in the Heart Surgery Forum. Some of the members who initiated this work are also present here, Professor Balram Meran and Dr. Sandeep Seth. So basically, we included 59 patients, age group of 42 to 62 years, treatment arm, where stem cell was given, and the control arm, where standard treatment was followed without giving stem cells. So it was again autologous, and the stem cell dose was around 20 million cells. And the endpoint analysis was echocardiography, stress thallium, left ventriculography, coronary angiography, and PET scanning of these patients. So these cells was injected during cardiovascular bypass surgery. So no extra time was taken to introduce stem cells into the degenerative myocardium. In the follow-up, you see that NYHA, which is New York Heart Association scale. On follow-up, there was decrease in this scale, followed by in echo, LV ejection fraction was increased. And during stress thallium also, we see that the number of scarred segment which was degenerated decreased. And if we see in the echo analysis, there were total around 56% improvement in them. And in 44% patient, there was same. There was no decrease or increase. And in 0 patient, there was a decrease in the infarcted segment. In stress thallium also, we see the improvement in around 26% and no change in 74% patients. This is the picture of reduction in the scar area. You can see the black area, pre-stem cells and the post-stem cell. There is a reduction in the scar area. This is after 6 months. And the PET also, we see here the normal viable area, normal metabolism of the anterior wall, suggestive of regeneration of that area following stem cells. This is again after 6 months. So in conclusion, this procedure of introducing stem cell is safe and viable, and we can harvest adequate number of stem cells during this process. And it is also beneficial to patients with scarred myocardium, but we need to have long-term follow-up. So keeping this in mind, we had another study which is called MI3 trial, which I was talking about, phase 3, multicentric double-blind randomized trial. We did it in around 250 cases. We included 5 centers throughout India to increase the number and to speed up the research. These are the list of the hospital throughout India. And basically, excuse me for this crowded slide, I want to say here, 250 cases was randomized. They were allocated to standard therapy and stem cell group. And out of this, we could able to analyze data around 117 in the standard therapy and around 71 in the stem cell group. Some of the patients, they died or they were lost to follow-up. This is after 1 year of the study. So we gave around this much volume of stem cells through intracoronary route. So endpoint analysis are subjected here. I'll not go into the detail. Let's focus on the result here. This is increase in ejection fraction. If you can see, this is stem cell group and non-stem cell. So there is significant difference between the stem cell versus non-stem cell group in terms of ejection fraction. This is stem cell trial deviate. In cases where we were not able to give good number of stem cells, like we are not able to get the cutoff value of stem cell, we still compare that with non-stem cell group and they were equal. That means cell dose really plays an important role in its efficiency. Next is again, if you see here, increase in ejection fraction upon the cell dose again. This is also not showing any improvement. If the cell dose is less, there's no improvement. If the cell dose is around 500 million cells, there is marked improvement. This is the impact of timing of stem cell transplantation. So group 1, where the stem cell were implanted around within 10 days of MI. Here it is between 10 to 21 days after MI. We see there that there is no difference between them. Majority of the paper which are published in MI, they say that injection of stem cells within 10 days is good enough. But in a country like India, a lot of time is wasted in bringing the patient and taking appointment and doing the surgery. So we extended this window period between 10 to 21 and we compared if the results are same. So we found this study that results are comparable. So in conclusion, it is safe. Cell dose indeed play an important role. The timing of stem cell administration, that is the window period, can be increased up to 3 weeks or 21 days. Of course, it needs validation in terms of more cell dose and the timing of infusion. Now I'll move on to dilated cardiomyopathy. We did 2 studies, initially a pilot study and the second one, which is both are published in JACC, which is a long-term follow-up up to 3 years. So these are the inclusion criteria. We took class 3 and class 4 patient, and these were the endpoint analysis to see the effect of stem cells transplanted in these patients. So basically 44, they divided into 2 groups, stem cell versus non-stem cell group. Number of bone marrow volume was around 35 ml, and mononuclear cells we gave around 90 million cells, and the route was intracoronary. So they were given after ligation of LCA and coronary sinus occlusion and given the cell through this LCA. So both echocardiography showed improvement in ejection fraction as well as in MRI. They show that these patients, they have improved their ejection fraction. In some patients, we took cardiac biopsy to see that there is no fibrosis, necrosis after going stem cells, or there are no abnormal vasculature developing by the introduction of the stem cells, because that was the prerequisite of our ethical committee members that, okay, you are giving stem cells, there might be some changes in the myocardial valve which might affect the patient later on. So, but we found that there was no abnormal vasculature, no inflammation or any primitive cells at that site. But we saw that there's an increase in myocyte versus CD34 ratio. So these cells, the ratio between the number of myocytes increased at the end of 3 months. So results is like in class 3, there is improvement in ejection fraction. There was no late arrhythmia or ischemic events. And 3 patients who were very symptomatic, but they were mobile and they remained in class 3. And some of them, they moved to class 2. But in NYHA class 4, there was not much improvement in them, and they remained, like they were saying that they were feeling better, but through endpoint analysis, we could not find any change in their ejection fraction. So in the control group, there was neither improvement in NYHA class nor improvement in ejection fraction. The second one is the long-term 3-year follow-up in these. There were total 85 patients, and the same protocol was followed as the earlier pilot study. Here also it says that in NYHA class 3, they were more stable, although 6 patients died during this group. Ejection fraction was improved from 23% to around 30%. In NYHA class 4, ejection fraction improvement was like not as compared to class 3, from 20 to 24%. If we compare the same result with the control group, there was no improvement in NYHA class, ejection fraction, and the mortality was around 30%. So in conclusion, we say that stem cell transplantation in class 3 it has shown improvement in NYHA and ejection fraction. Class 4, which is one of the sickest group, they might not be benefit. Again, a question mark is there, or they may need repeated injection. All these patients, they received single dose and single intervention. Stem cell transplantation is safe, that there's no harm to these patients. And now we need to do more studies in larger number of patients and much more controlled and tight environment to see the effect. So what are the lessons learned? So during these 3 clinical trials, we say that stem cell dose is important factor. But taking bone marrow from these patients is very invasive. You cannot increase the dose like 100 ml or 200 ml of bone marrow. So we thought that why not increase or expand these cells in the CGMP, is good clinical manufacturing practices where we can use mesenchymal stem cells, scale up the number of stem cells, and can give in a repeated manner. So this is the facility which was inaugurated by our health minister and our director, Professor M.C. Mishra, in 2014. And we have standardized the protocol of stem cell extraction and isolation and culture and cryopreservation. So the second aspect is we are giving stem cells which are naive. That means they are not predisposed or primed towards cardiomyocytes. So they need to integrate into the cardiac muscle cells to do contraction. So what if we make these cells primed towards cardiac lineage? It will be much better. So what are the different factors which control cardiomyogenesis? So these are 2 students who are working on different chemical cytokines to make these cells primed towards cardiomyocytes. So they are observing what are the morphological changes, what are the gene transcript, protein analysis, and functionality, which is very important. So I'll just quickly say that multinucleation is a hallmark of cardiac cells. We can see multinucleation, muscle-like islands in the cells, and striation, like myotube-like formation of these stem cells when they are primed. They express all cardiac-related markers like myosin light chain, cardiac troponin I after differentiation. And functionality also, they show that they can be excited and they can generate action potential when you excite them, but using potassium chloride. So this video is not working. These cells, they contract in media, in culture dish. They show they are functionally active. So for example of bench to bedside, away from cardiac diseases, this is a very common disease in India, ocular surface occlusion, like the cornea is totally scarred because of chemical or alkali burn. The patient is not able to see and needs help, and there's a morbidity in the eye. So we use some stem cells of the eye, we grew them in the lab and try to transplant these stem cells into this cornea. So after 6 months, 11, and around 17 months, the corneal surface is clear and the vision is almost normal. So this has been done in more than 400 cases in AIIMS, and other hospitals have also done this. The second one is vitiligo, that is loss of melanocytes or pigmentation. We tried to use hair follicle, like we plugged some hair follicle, derived hair follicle stem cells, made them into melanocytes in the culture and see if they can regenerate melanocytes in the skin. So we did in 15 cases after ethical approval, and we saw that after 4 years of follow-up, there's no loss of melanocytes in them and they are doing good. Second is very important in stem cell and tissue engineering, and we targeted to replace or substitute for cornea or long bone defect. So in cornea, we made a polycaprolactone scaffold, which when it is mixed in fluid, it becomes transparent. So we tried to grow stem cell over it, and in animal model studies, it has shown good biocompatibility. So after getting clearance, we might go into the pilot study in humans. Second is bone defect, like because of the trauma, as sir said, there's a bone defect. So can we have a scaffold which can have stem cells and osteoinductive make bones over it? So we have seen that this mixture of chitosan, hydroxyapatite, and polycaprolactone has a good mechanical strength, biocompatibility, good pore size. It can hold stem cells, and it can also slowly degenerate in the body when natural bone formation is there. And in animal model, you can see here we have injected at the back of the mice, and when you take it out after 3 months, and you see that there is a calcification and bone formation over X-ray images. And in histopathological examination, there's no abnormal tissue around this bone formation. Done, finished. Yeah, this is the future perspective in mind to have artificial skin, blood vessels, which can be helpful in trauma cases and some other cardiovascular diseases. Thank you so much, and I would like to thank all the funding agency and stem cell study group of AIMS and IIT Delhi. Thank you so much.
Merci.
Thank you very much, Madam Mohanty, for this excellent presentation and your results obtained with cell transplants. It's worth noting that you, above all, used bone marrow cells and not mesenchyma cells. 2 recent studies were reported. You had the trial chart. This was a report in Rome. They used mesenchymatous cells, and the results weren't very good. With bone marrow cells, the Tuxcell study was reported on in Chicago at the ACC in 2016, and also they got really positive results, just like you. So it appears that the bone marrow cells are better than mesenchymatous cells in these stem cell transplants. Are there any questions? Daniel?
Simplement un commentaire, c'est un magnifique sujet de recherche.
It's a wonderful research topic, but there's a long way to go before we can use this and get positive results in human clinical trials.
In fact, I am asking Dr. Sujata Mohanty to get these scaffolds made so that we can have the cardiovascular patches, cardiovascular tubes, which we can use in the patients later on. When we exercise the muscles in case of tetralogy of Fallot when repairing it, I gave her some muscle cells also to see whether the stem cells grown in the laboratory and what I have supplied naturally, how similar these are. Maybe she can just tell about it. What did she see?
Yeah, I fully agree with the comments given by this. Like hematopoietic mononuclear cells are much better because it's a composition of different type of cells. It's endothelial cells, then hematopoietic, and mesenchymal are a pure population of separate cells. But we need to do more study and comparative study to see MSC versus mononuclear cells. Isolated study can say it's good, it's doing good, but we need to have a study on the same platform comparing 2 types of stem cells. Still, it's very controversy regarding mesenchymal stem cells. People have said that adipose tissue-derived mesenchymal stem cells has good potential. And regarding the cardiac patch, we are collaborating with IIT Delhi, and the cardiac tissue-derived stem cells have equivalent and best propensity to towards beating, and they are synchronized towards beating over a scaffold.